Hello guys, welcome back. This is Dr Ranjith here again. So today I wanted to discuss something about your musculoskeletal system, which I had not discussed in the routine classes, right? So we'll see a quick overview of musculoskeletal system, maybe a couple of questions related to the pathogens in musculoskeletal system, right? So before going into it, as usual, we have a preliminary idea of how a skeletal muscle will, disease of a skeletal muscle will affect the patients, right? And then we'll look at how. Just a second. I hope I'm audible, right? Okay, apologies for the initial one. Okay, I'm going to start again. So today we'll be discussing about musculoskeletal system because I have not discussed about musculoskeletal system much in the past. So I thought that we'll have a quick overview of musculoskeletal system and then maybe a few MCQs related to the musculoskeletal system so that it'll be useful for you if there is any questions which comes in the pathology aspect of muscle. Generally, muscle is not much concentrated from the pathological perspective because it's a bit complicated to understand one. And am I audible, Shashti and Yuvraj? If so, just give me a hi. Not concentrated much for the reason that it's more of an super specialty or subspecialty from general pathology. It needs lots of expertise and lots of staying to do a muscle biopsy and to interpret a muscle biopsy, right? So what we'll be doing first here is we'll be looking at the muscle biopsies, the types of damage which happens in muscle, maybe a couple of diseases, and we'll have a few questions related to that, right? Okay. And for your upcoming NEET exam, and I'm starting to start something new of called as a 360 series, and we'll be seeing about a disease in particular and MCQs related to that in the form of special classes. We'll be seeing it from November. Hopefully that'll be helpful for your NEET PG exam, right? So let's start and discuss something about muscle first, right? So you take a muscle. I do have two types of muscle fibers. I'm sure that you must have been aware of that when you're from your physiology as well. We call them type 1 fiber and type 2 fiber. For a sustained force, I use a type 1 fiber. When I want to do a fast movement, I use a type 2 fiber. In other words, I'm going to sprint. My type 2 fibers are more important for me. The power produced in a type 2 fiber is more. The enzyme activity is also different. Most of the muscle fiber in a biopsy, I'm going to base what a type 2 fiber will look like in a muscle biopsy in different strain and what a type 1 fiber will look like in a different strain, right? So we have to have a basic understanding of how type 1 fiber and type 2 fiber differ. This is there in Robbins. This table is required for me to understand about the muscle biopsy, right? So as I said that a type 1 fiber is more of a sustained force. It's going to help me for a sustained force like an aerobic exercise. I need a force, constant force, right? Type 2 fibers is for a fast movement. If I want to sprint or something, I'll have it. Type 2 fibers will have the energy burst, right? It'll have a perfect burst, and I'm going to call it a type 2 fiber. Type 1 fiber, the energy produced will be low. The glycogen content will be low. But type 1 is a sustained force, right? So it will not undergo fatigue much. I will run fast with the help of my type 2 fiber, but I cannot sprint forever. So the fatigue will be more in a type 2 fiber, right? So compared to a fatigue quantity, type 1 fiber will be more resistant to fatigue, right? Type 1 is going to become more resistant to fatigue, and type 2 fiber is less resistant to fatigue, or it undergoes fatigue easily, right? Because I can destroy them easily because of the high energy output produced. When I come to power retained, power produced, here there's going to be low power produced. Here sprinting, it'll require a high power production, right? Same goes with my enzyme activity, enzyme metabolism, everything. What I'm more concentrated about is few things. Mitochondria will be high here, mitochondria will be low here. These are more theoretical aspect. What is required for me is the staining pattern, right? So when I'm going to do a staining, like we have different types of staining in muscle biopsy. We have ATPase staining at different pH 4.3 and 9.4 to interpret how it looks, and we have NAD, your NADH NADH tetrazoline reductase staining as well, right? So NADH tetrazoline reductase staining and my ATP staining is what I do in a routine muscle biopsy, right? So when I have an NADH TR stands for my tetrazoline reductase, a type 1 muscle fiber will appear dark in color, right? I'll share you the pictures after this class. I'll share a few pictures in the Telegram group for you to interpret what type of muscle fiber is, because those interpretations required for me to understand what regenerates after an injury or not, right? And I'm going to go in with the same NADH tetrazoline reductase a type 2 muscle fiber will look light in color. Same I can use for an ATPase. I'll do ATPase staining for both of them. And I say ATPase, as I said, there are 2 pH in which muscle fibers are stained, 4.3 pH and 9.4 pH, right? And 9.4 pH. Okay, so in 4.3 pH, a type 1 fiber will be dark, and in 9.4 pH, a type 1 fiber will be light. Here it's going to be dark, and this will be light. Both of them will have a brownish hue only, light and a darker brownish hue. Here this will be light, type 2 muscle fiber, here it will be dark. Why I need this is, for a muscle staining in a normal H&E, I will not be able to appreciate which is type 1 fiber and which is type 2 fiber, because after an atrophy, one fiber predominantly regenerates more compared to the other one. So I need to know what type of damage it is. Is it denervation or renervation? Is inflammation induced damage or not? For that, this staining is going to help. Again, these are just basics for me to understand it. Fine. So when I take about a skeletal muscle atrophy, Robbins explains them clearly that what is the difference between normal, denervation and a renervation or regeneration, right? So take a skeletal muscle atrophy. We have different types of skeletal muscle atrophy. So skeletal muscle atrophy, I can use them for a biopsy to maybe to identify dermatomyositis, polymyositis, or maybe sometimes your Duchenne's muscular dystrophy as well. Both inflammatory myopathies and congenital myopathies, I need to know about it. Fine. So I have few groups of skeletal muscle atrophies. Like I have clusters or group atrophy of muscle fibers. Those are clearly seen in a neurogenic disease. When I have a perifascicular atrophy, that's very, very classical for dermatomyositis, right? When I have a preferentially a type 2 muscle fiber atrophy, that's suggestive of an chronic steroid abuse. So in a skeletal muscle atrophy, I group them into 3 categories. The first one is in cluster atrophy. Cluster or my group of fibers atrophy. Group of fibers atrophy is classically suggestive of a neurogenic disorder. Can be a simple, simple denervation, right? You cut an ulnar nerve, injured an ulnar nerve, my hypothenar muscle will undergo atrophy, and that will be cluster atrophy. The entire fiber undergoes atrophy, right? That's classical for a cluster atrophy. In a neurogenic disorder, just a denervation. If I want to commit it simple, I'm just going to call it a denervation atrophy. Is going to look like this, fine. So how it looks is, I'm going to denervate. Let's say that I'm having 2 nerve fibers. For our understanding, we'll use 2 nerve fibers, and each of the nerve fibers are going to supply a specific group of muscle fibers, right? And it will be intermixed, right? The muscle innervation obviously will be intermixed. So when I'm going to cut this nerve, this entire group undergoes atrophy. It's not just a fascicle, the entire group undergoes atrophy. So this is I'm going to call it a cluster atrophy or a nerve atrophy. It might be the main branch of a ulnar nerve or a subdivision of the ulnar nerve. So whatever nerve it cuts, the entire muscle fiber which supplies them will undergo atrophy. So how will an atrophied muscle fiber look after denervation is, it becomes more angulated. See, when I look at normal muscle fiber, they look like this. They look polygonal, right? Most of the muscle fiber will be polygonal normally on a microscopy, on a H&E or in your NADH-DR or your ATPase, right? When it undergoes atrophy, that's very, very classical. They're going to become triangular. They'll become very small. They'll become angulated. They'll become triangular. Again, for a comparison, a normal muscle fiber will be round and polygonal, right? So this entire thing is an atrophied muscle fiber. They look smaller. They'll become extremely small muscle fiber. They'll become angulated. They'll become triangular. So when I have this type of atrophy, I'm going to suspect some denervation is going on in this patient, a denervation atrophy. Once they start to regenerate, see, when I'm going to do a surgical thing or a correction with the help of a slow grade physiotherapy, muscle also will regenerate. You must have read about validating degeneration and regeneration. So during regeneration, I do have these fibers might come back to normal with the help of my satellite cells. They'll appear more bigger than usual, right? So once they start to renervate, so during renervation, what I'm going to see is the muscle fibers will be more bigger than usual, or the fascicles will be more bigger than usual. So I know that, okay, this something is happening to the patient, more bigger than usual, it is coming back, right? So these are clues for me to say that there is a denervation going on or a renervation going on. This is for a cluster atrophy. When I take a Duchenne's muscular dystrophy, as I said that, the second type of atrophy I'm going to call it perifascicular atrophy. Fine. Not a Duchenne's muscular dystrophy. Perifascicular atrophy is very, very characteristic of an dermatomyositis. Dermatomyositis biopsies are done. The pathogens of dermatomyositis is based on the blood vessel which supplies them. So entire group which is supplied by that blood vessel, if that blood vessel affected, the entire fascicle surrounding them will be affected, right? Because if I remember the fascicles, your muscle, your architecture will be like this. These are a group of the muscles inside which I have entire fibers, and inside I have multiple fibers, right? Like your endoneurium, perineurium, muscle is also looking like this, right? So the tiny round ones are my muscle fibers, and the entire thing is my fascicle. So what happens is, let's assume there's a blood vessel here which supplies this fascicle. If this is undergoing a vasculitis, which is the pathogens of a dermatomyositis, the entire thing is going to get died. That's my perifascicular atrophy, very characteristic of a dermatomyositis, which is a vascular pathogenesis, right? So third type of atrophy is when my type 2 muscle fibers alone get damaged. But type 2 muscle atrophy, this is very, very classical for an steroid abuse. Fine. Okay, so a type 2 atrophy with sparing of type 1 fibers, only type 2 is gone, right? It's very, very classic of a long-term steroid abuse. Okay, I can easily appreciate them when a muscle biopsy. In muscle biopsy, also I can say this is a person who's abused steroid, maybe for the purpose of having more fast movements, because type 2 muscle fibers is going to give the burst of energy. So when I give steroids, the burst of energy is going to be more. I'll have the finding, right? So these three are the groups of atrophy, what happens to a skeletal muscle. Let's see an MCQ based on that, and then let's go to the next one. Fine. Okay, this is the thing. First question we'll see: a 22-year-old woman injured her leg in a motor vehicle accident and subsequently suffers weakness of her lower limb. A biopsy of gastrocnemius muscle is done and obtained after 4 months of the injury. Right? Actually, the muscle biopsies also sometimes will tell me what type of muscle fiber is predominant. When I say a biopsy done from the soleus muscle, which will predominantly having a type 1 muscle fiber. On the other hand, pectoralis muscle will predominantly have a type 2 muscle fiber. That's how the distribution of muscle fiber is more oriented. Gastrocnemius is one of the commonest muscle which is being biopsied, and they'll have both mixture of type 1 as well as type 2 fibers. In HNE, as I said, I will not be able to appreciate, right? So I have a classical history of a motor vehicle accident. After that, I'm having an injury. Now, let's look at the image, then we'll come to the MCQ points, right? So look at this image, normal, right? So am I right in saying that I'm having atrophy of a group of muscle fibers here? All of them are appearing smaller. They are smaller, they are angulated, right? So all these are my cluster atrophy or a group atrophy. So when I say entire cluster of muscle fibers undergoing atrophy, the commonest etiology is going to be your denervation, which would be secondary to my motor vehicle accident, right? I can have a patient with a motor vehicle accident. Secondary to that, I'm having a damage. So this is nothing but a cluster atrophy. Fine. So that's how I'm going to understand a muscle biopsy, and that's how I'll be able to diagnose a muscle biopsy. This is just a denervation-induced atrophy. Maybe if renervation starts, I'm taking the biopsy after physiotherapy and nerve stimulation, let's say after 10-20 months. So this might become bigger than usual. So then I'll call it an renervation-induced thing. Fine. So that's about the first one. Okay. We'll look at the second MCQ, and maybe we'll try to answer a few things and discuss few things related to an MCQ. Okay. A 60-year-old person recovering from a flu complains of fatigability. He reports he cannot climb the stairs 2 at a time, which he used to do usually, which means my proximal muscles are more affected than the distal muscle, because climbing a stair requires a proximal muscle thing, right? He also describes pain in the thighs. A muscle biopsy is shown here, which demonstrate mononuclear infiltrates, chiefly in the endomysium. IHC shows that these infiltrates are predominantly CD8 positive T cells. What is my appropriate diagnosis, right? So here there are two things to notice: where I'm seeing the inflammation is the first one, and what type of cells is the second one. This is a discussion going to be based totally on my inflammatory myopathies, right? I'm sure you know the three different major types of inflammatory myopathies: dermatomyositis, inclusion body myositis, and polymyositis. All of them have different pathogenesis. All of them have different microscopic finding as well, right? So we'll look at the diseases, then we'll come back to this and see what will be the answer. Okay. So the first thing here, we're going to discuss about inflammatory myopathies. So when I say inflammatory myopathies, the first inflammatory myopathy which I'm going to discuss is dermatomyositis. Dermatomyositis is definitely the commoner of the three compared to my polymyositis and inclusion body myositis. Dermatomyositis don't go with the age alone, because I have something called juvenile dermatomyositis and adult dermatomyositis. So it can happen both in adults and children. Juvenile, the onset will be around 7 years of age. Adult, like any other adult, right? So I do have, don't go with the age. I do have different types of dermatomyositis, both juvenile and my adult onset. See, it's dermatomyositis. I can easily classify or differentiate dermatomyositis from my polymyositis and inclusion body myositis, because these will have all the dermatological signs. I'm sure you must have listened to these dermatological signs. Okay, I'll come to Shashti. I'm sure you must have seen about the dermatological signs. You must have heard about the Gottron's papule, the Scholl sign, the heliotropic rash. So this will have both the skin manifestations plus muscle manifestations. It will have both. On the other hand, polymyositis will not have a skin manifestation. Inclusion body myositis will not have a skin manifestation. The only one with skin manifestation is going to be your dermatomyositis, right? So look at the pathogenesis, then we'll see what I'm going to see in microscopy and also what type of cells I'll see here. It's an immunological disorder, autoimmune disorder, obviously, right? So it's primarily a vascular disorder which affects the vessels of my skin as well as the vessels of my muscle. That's all, right? When you look at the pathogens of dermatomyositis, they are primarily a vascular disease. It's not a myopathy as such. It's a vasculopathy. Secondary to that, I am having injury to the muscle. This vascular disease affects my skin and affects my muscle, right? So it's a vascular injury. So that's the reason one of the points to diagnose dermatomyositis is you will have telangiectatic vessels in your nail beds folds, in your eyelids. They are just dilated vessels, because vessel is getting injured. The tiny ones will get dilated under the nail beds, under the eyelids. Those are clues for me in the clinical examination, right? So what happens here is there are few autoantibodies which is going to trigger the complement cascade, which is going to attract more lymphocytes, which is going to destroy muscle fibers, right? There are few autoantibodies which we have found it useful to diagnosis, and we have seen them consistently in patients, right? What are the autoantibodies which comes to your mind? We're just making sure we know all the basics, then we'll go to the pathogenesis per se. One of the important autoantibodies is anti-MI2 antibodies, right? So anti-MI2 antibodies, it's a helicase which is involved in the nucleosomal remodeling. We'll just say it's in helicase. Okay, so it's directed against helicase. When a person has more amount of anti-MI2 antibodies, these patients will have lots of skin manifestations in the form of Gottron's papules and a heliotropic rash. They are very strongly associated with, this has come in an MCQ, with Gottron's papules and your heliotrope rash. Okay, so there are few antibodies. Again, I have few antibodies which are more classically seen in paraneoplastic and juvenile dermatomyositis. We'll see at them soon, right? The second group of antibody, I'm sure this you must have heard for sure, right? These are much more famous than my MI2, anti-Jo1, right? So anti-Jo1 antibodies are associated with an interstitial lung disease. It's vasculitis, right? So it can affect anywhere, not only my muscle and my dermatological action, which though it is predominant, right? They are anti-Jo1 antibodies. First, the one, they are directed against, okay, like my helicase in my anti-MI2, these are directed against an histidyl tRNA synthase, right? They are histidyl tRNA synthase. So they directed against the antibody against the histidyl tRNA synthase. I'm calling it Jo1. The Jo1 antibody is more associated with an interstitial lung disease. It's also associated with skin manifestation, but here the entire group of manifestations is called as a mechanic hand. Mechanic hands is a very classical finding seen in anti-Jo1 antibody induced myositis, right? So here again, there is more incidence associated with an interstitial lung disease, arthritis. Okay, fine. Okay, and I said that this will be more commonly having an, just a second. Sorry, ignore the sound for some time. Sorry guys. Fine. So this will be having more of interstitial lung disease. You'll have your non-erosive arthritis, and in the skin manifestation, they are more commonly associated with mechanic hands, right? So these are things which I'm going to see in associated with an anti-Jovan antibodies. The third group of antibodies which are also seen here is my anti-P155 or your P140 antibodies. The P stands for the protein and the kilodalton, right? Here these are more associated with an paraneoplastic. I'm writing PNS for paraneoplastic, and also juvenile dermatomyositis, right? So more common in these two conditions of my dermatomyositis, right? So though I am not exactly sure about the pathogenesis, how these autoantibodies are going to involve in the pathogenesis of destruction of the muscle, but these are the ones which are commonly seen here, right? So here it is a direct injury to my muscle fibers due to the vascular damage. So what happens is, let's assume I'm having a vessel here. This vessel is going to be affected. So whatever the vessel supplies, I'll have a muscle damage. So this vessel are predominantly affected by my CD4 T cells, which will destroy the vessel and subsequent destroy of the your muscle as well, right? It's primarily in CD4 T cell related damage. So in my microscopy, I'll have CD4 T helper cells. This CD4 T helper cells, when it's involved, there'll be increase in the complement mediated destruction also. There'll be increase in complement activation because of the antibody might be, and I'm seeing complement deposition in my microscopy when I'm doing an immunofluorescence, because immunofluorescence is a method by which I can evaluate almost every autoimmune disorder. Here I will see them in my immunofluorescence as well, right? So what I'm going to see in microscopy is there are few things which are very, very characteristic. The inflammation will be restricted to perivascular. Most of the time the inflammation will be perivascular. It will not be throughout my muscle, like the question said, an endomysial inflammation completely throughout the muscle. I won't see that. The lymphomononuclear infiltrate will be almost always surrounding my blood vessels, and as I said that, you'll have a perivascular atrophy, which just now we saw, right? Second thing, if I'm going to do an IHC, almost every T cells they will be CD4 positive. Our question didn't have CD4 positivity or CD8 positivity. We'll go back to the question soon. And if I'm going to do a complement assay, C529, your MAC complex, right? The MAC complex will be easily deposited, which will be seen at the site of damage, telling us that the damage is due to my inflammation, right? Or my complement activation, which is secondary nothing but inflammation, right? It's an inflammation mediated damage which is causing all of them, right? This is what I'm going to see in my dermatomyositis, right? When I come to polymyositis is first thing is it's adult onset. Our question, the patient was 60+-year-old group, right? So I'm going to we'll just discuss a few words about polymyositis, then I'll go to the next question. Okay, so it's an adult onset myopathy. It's kind of more common in the US compared to our condition, compared to our subcontinent. It's an adult onset myopathy where I'll have myalgia and weakness, which is almost similar to my dermatomyositis. The only unique thing is your myalgia and weakness will be similar to that, but my only difference is I won't have dermatological manifestations, no skin signs. These are primarily directed against destruction of my muscle fibers, and the pathogenesis, I'm not sure what triggers them, but what I'm seeing here is they are CD8 positive T cells. The CD8 positive T cells infiltrate my muscle directly and destroy the muscle antigen. This is not like dermatomyositis where I'm going to have an involvement of the vessel and then muscle antigen. It's a direct antigen, direct damage of the mononuclear T cells. The mononuclear cells, which is CD8 positive T cells, will directly go and destroys the muscle antigen. So which means my inflammation is going to be florid. It will not be perivascular, it will be endomysial inflammation. What I'm going to see in microscopy is an endomysial inflammation, like what was said in the question. When I say endomysial, if this is my muscle biopsy, my fragments of muscle biopsy, I'll have inflammation all around this. It will be full of them, right? Lymphomononuclear infiltrates. And if I'm going to do an IHC, there'll be CD8 positive, right? And I have atrophy for sure. You'll have necrotic, you'll have atrophic and regenerating fibers. Again, when I say it's an endomysial inflammation, I won't have a pattern, right? It's going inside. If it's very much close to this muscle fiber what I marked, that will get destroyed. So the destruction of the muscle fiber, the atrophy of the muscle fiber will be patchy and will be random. Right? It will be random and patchy atrophy. Again, that is characteristic findings seen in your polymyositis. Okay, so it'll be random and patchy all over the thing, right? That's what our question was. We'll go to the question, have a look at it. Elderly person, I'm having a proximal muscle weakness, that's characteristic, and these are my muscle fibers. Look, it's definitely not oriented to anything, full of it CD8 positive cells. That is your polymyositis. Inclusion body myositis is also a disease seen in the adulthood only. An inclusion body myositis, as the name says, I'll see a characteristic inclusion body which is highlighted on a modified Gomori trichrome stain. When you do a modified Gomori trichrome stain, a red color inclusion body will be seen in the muscle that I can easily identify that as an inclusion body myositis. Fine. So go to the next question. We'll see a few things about this and we'll come to the answer. Fine. Okay, this is A and this is B. Since they are marked, I'll just read through the question and look at the answer. A 44-year-old person has worsening of exercise intolerance the past year. On the physical examination, 4 out of 5 motor strength in the extremities, but no muscle pain or joint pain. He has splitting edema to the knees. Chest radiograph shows cardiomegaly, pulmonary edema, pleural effusion. A deltoid muscle biopsy is obtained, and the IHC is done for dystrophin. Right? I'm having A is normal and B is the patient. What is the most probable diagnosis? See, when I'm going to do something related to dystrophin, I'm sure I already know that what diagnosis I'm looking for. I'm looking for only one diagnosis, which is my Duchenne's muscular dystrophy, right? Or my Becker's muscular dystrophy, that is also related to dystrophin. So here, if this is normal dystrophin, you can see that dystrophin is seen all throughout my muscle fibers, right? That's how the normal pattern of dystrophin will be. I'll draw dystrophin. They are membrane-related proteins, so it will be uniformly highlighting every muscle fiber. But when you look at this patient, are you seeing dystrophin or not? It is present, right? It is not completely normal, but it is definitely present. So obviously it has to be in Becker's muscular dystrophy. If I have option E as Duchenne's muscular dystrophy, unlikely. Clinically itself unlikely. Do you think a Duchenne muscular dystrophy patient will survive till 44 years? Unlikely, right? I lose the patient with cardiovascular collapse much earlier than the 44 than the age mentioned here. So clinically also it's a Becker's muscular dystrophy, and IHC wise my dystrophin is a bit minimal compared to my normal, so it's definitely Becker's muscular dystrophy, right? We'll just see a few things related to Duchenne's and Becker's muscular dystrophy. Both of them are your X-linked disorders, right? They are inherited disorders. They are inherited muscular dystrophies. So when you look at Duchenne's or Becker, both of them are problem in my dystrophin. There are lots of proteins which are related to my muscles function. Dystrophin, you have dystrobrevin, you have synaptophins, you have caveolin. There are many things. Based on that, I have lots of inherited myopathies. Again, inherited myopathies is a very huge topic. Maybe we'll convince ourselves to Duchenne's and my Becker's muscular dystrophy. Duchenne's and Becker's muscular dystrophy, the only difference is Duchenne's will have a complete absence of dystrophin, and Becker's will have a reduction in the amount of dystrophin, right? That's a major difference between both. Duchenne's muscular dystrophy, both the same. The dystrophin is X-linked inheritance. The Duchenne's as well as Becker's muscular dystrophy is seen in the X chromosome, the dystrophin component, right? It's an X-linked disorder. Actually, the image what was given was not required for the diagnosis of Duchenne's or Becker's muscular dystrophy. Clinical features, I'm sure you will remember for Duchenne's muscular dystrophy. There are two classical findings. One is Gover's sign. Gover's sign will be positive in case of DMD. We look at DMD, then we look at BMD. Right? Gover's sign is the entire patient's muscle is weak, so the patient will not be able to sit properly, walk properly. So from the sitting posture to a getting up posture, they'll have to climb on themselves. They'll keep the hand on the knees, on the hip, then they'll climb on themselves. Climbing on themselves, which signifies the muscle weakness. That's a very characteristic find of a Duchenne's muscular dystrophy. Second thing is pseudohypertrophy of cough, right? They calf pseudohypertrophy. We'll see why there's pseudohypertrophy soon. When I say hypertrophy, which means it's increase in the muscle size, right? I'm calling it pseudohypertrophy. We'll see what happens here. So I'm going to have a patient with a muscular dystrophy. Dystrophin is not present properly, so these muscle fibers are going to undergo atrophy. See, dystrophin is something which is going to take care of the force and gradually transmit it through the entire cell. That's why you see them continuously throughout the entire cell membrane. So when my dystrophin is gone, my muscle fiber is going to get degenerated. I'll have segmental degeneration. It will try to regenerate, but again it will get destroyed. So I have a muscle fiber. If in this field I'm having 4 or 5 muscle fibers here, they'll undergo atrophy. They'll become smaller, they'll try to regenerate. Some of them might regenerate, but most of them will destroy. So over the period of chronic damage, what's going to happen is all these atrophied muscle fiber, at one point of time they're going to get burnt out. When the atrophy progresses, all these atrophied muscle fiber will be replaced by fat. When they are replaced by fat, it looks more bulky to the naked eye, right? It will be full of fat muscle fibers here. Fat should be clear. I'm drawing it in green color with a clear vacuole. When it's filled by fat, I can say that this is like an end stage. It will not come back because my regenerative capacity is gone and all the muscles are dead, right? So it's replaced by fat. When I look at the naked eye, it look more bulky. So I'm going to call it an pseudo hypertrophy of cough. It's not actually hypertrophy, it's fat which is making it look bigger, so we call it pseudo hypertrophy of cough. For any case of DMD or BMD, muscle biopsy is not indicated in the current era. You don't want to do muscle biopsy. So if you want to do, you can do it and you can appreciate the dystrophin gene being absent totally or being reduced. The way to evaluate first is my creatine phosphokinase. Creatine kinase will help me. Definitely my muscle specific creatine kinase is elevated. That will tell me, okay, there's some muscle destruction going on. Second thing, both of them are diagnosed based on genetic testing only. If a question comes on the investigation of choice or the next line of investigation when it's suspected Duchenne or Becker's muscular dystrophy, I'm going to do a test called as an MLPA. MLPA stands for your multiplex ligation dependent probe amplification. Okay. It's multiplex ligation dependent probe amplification. That's a way I'm going to use for my both Duchenne's and Becker's muscular dystrophy, because in both of them the genetic problem, what happens is there are going to be deletion of multiple exons. This is a test which is done for deletion of a gene or any multiple exons. For example, your Angelman-Prader-Willi, I have gene deletion. I use the same MLPA, fine. So MLPA is a test done for gene deletion. That is the investigation of choice. You are going to suspect Duchenne's or Becker. Because muscle biopsy is a painful procedure, with this I can have a perfect diagnosis. So why to go for muscle biopsy, do dystrophin, which is going to be difficult, right? So I'm going to diagnose with genetic analysis. I don't want to subject the patient to a muscle pain because these patients are already losing their muscle. So when I'm going to use a biopsy again, they're going to lose more and more muscle, more and more damage is going to that. I'm not going to trigger the damage, right? So what is MLPA based on and how it is done is, so what I'll do is, first I'll take the patient's DNA, right? The patient's DNA is taken and they are broken into single standard pieces, multiple single standard pieces, right? So to this I'm going to add the primer. So what primer does is, it will be complementary to it. Whatever the base passes is going to be complementary to it. Then I'll have a linker protein, right? I'll have a linker DNA which is going to just bind to these. It's going to bind because I know which point I cut them, so it's going to bind to them. So once it binds, then I'm going to amplify. The linker is my ligation point. So what I'm doing is, I know that, okay, this is one exon, this second exon, I'm going to bind these two exons. Once this binding happens, once the ligation happens, only then it can amplify. If the ligation is absent, it cannot amplify. Let's say that this exon 1, exon 2, exon 3, exon 4, exon 5, exon 6, 7 and 8, right? 1 to 8 my exons are. I know I can bind these two. I know I can bind these two. When these two are bound, it will amplify. So in the amplification, what happens? Exon 1 allow a spike, exon 2 allow a spike. I said 3, 4, 5, 6, 7 and 8, right? Exon 3 and 4 allow a spike. Let's say that the patient is having a disease, so exon 6 is not there. So do you think this will link to exon 6? Because exon 6 is not there in the patient, so this linkage will not happen. When the ligation doesn't happen, it will not amplify. So what happens is, I'm going to have an empty thing in my exon 5, little bit amplification, exon 6 totally lost, right? It's going to be totally lost here. Again, if this links again, my exon 7 and exon 8 links. So by looking at this, I'll be able to say that, okay, these exons are not amplified properly, so I'm having a problem that exon is getting deleted. That's what I do primarily in my multiplex ligation dependent probe amplification. It helps me to diagnose deletion of my exons. Anywhere when I have gene deletion or a deletion of exons, I'm going to use this, okay? Or exonic deletion in any pathogenesis, I'm going to use this. Remember 3 diseases when it comes to my MLPA. First, obviously my DMD and my Becker's muscular dystrophy. The second thing is, as I said, my imprinting disorder. When I say imprinting disorder, your Angelman Prader-Willi. Both of them I'm going to use MLPA only, but a modification called as methylation specific MLPA. The next one I might use them for Charcot-Marie-Tooth disease. So in Charcot-Marie-Tooth disease, what I'll be doing is I'll be doing amplification. There is not deletion. Both for deletion and amplification I can use this, or duplication I can use this. So all these investigations, all these three diseases, the first line of investigation is MLPA only. Fine. So once I do an MLPA, it'll tell me not only is Duchenne's muscular dystrophy, it'll tell me exactly what axon is affected. Same, it can help for Becker's muscular dystrophy as well. Duchenne is very, very severe. I may lose the patient in the second year of life maximum. Becker is well progressed for long, right? Second decade is maximum time a Duchenne's patient can survive, right? So going back to the question, so what we saw was there's a completely normal staining. Here is a reduced staining, so it has to be in Becker's muscular dystrophy, fine. Last but one. A 5-year-old person develops increase in muscle weakness. He is unable to play with other children, quickly becomes tired and is unable to keep up with them. Again, no deformities, muscle synthesis 4/5, more apparent weakness in the proximal muscles. Lab shows 689 creatine kinase, it is definitely elevated. Muscle biopsy is done, which shows here. As I said here, there's atrophy here, there's atrophy here, there's atrophy here, there's atrophy here, right? Patchy atrophy is there. I know there's a muscle atrophy, and I know there's definitely an elevated creatine kinase in a very young person. So my acquired disease is secondary now. My inherited disease is more common here, right? So muscle biopsy shows atrophy. Which of the following tests would be the most appropriate to diagnose the patient? I won't do an absolute eosinophil count. Where I will do this if I'm going to suspect a parasitic infection. The muscle biopsy doesn't show any inclusions or any parasite. Neither I have a clinical history of any travel related or any consumption of meat, unhygienic, I don't have. So unlikely to be trichinosis, which can happen there, or your trypanosomiasis, which can happen here. I don't have any history leading to it, so unlikely to be having eosinophils in the blood. Immunohistochemical stain for dystrophin, yes, it might help because my primary diagnosis with the age is my Duchenne's muscular dystrophy, and here it will be completely negative. CGG repeats chromosome XP17. See, repeat disorder could be a Fragile X syndrome or a myotonic dystrophy. It will not be presenting like this way, fine. Presence of oligoclonal bands in your CSF is diagnostic of multiple sclerosis. That's not the age group for multiple sclerosis, and that's not the presentation for multiple sclerosis as well, right? So that's also not the right answer. The right answer here, my clinical diagnosis is Duchenne's muscular dystrophy, and the way I'm going to go is dystrophin IHC, right? Dystrophin IHC will definitely help me in the diagnosis of Duchenne's muscular dystrophy, fine. So what we have seen here is we have seen few things related to muscle pathogenesis. I know muscle is something what we don't concentrate routinely about. We generally ignore muscle. So I thought that we'll take some time and read about muscle. We have seen a few diseases. There are a few more inherited myopathies there. We will split them and see in different places, right? Because muscle biopsy is bit we don't concentrate much on. If it comes in a next or a NEET pattern, when an approach based question is going to come, it might help us, right? So quick session on both the muscle lesions. We had 4 MCQs and we discussed something related to that, fine. Hopefully we'll be able to excel muscle biopsies also soon, and thank you for your time. Thank you for watching. Okay. As I said that what I was saying is from November onwards we'll have a particular topic. We're going to focus on a particular topic and we'll be seeing about the pathogens of the topic, the features of the topic, the clinical features. Let's say if it's G6PD deficiency, how the patient is going to present, the pathogenesis and the approach. Because I want to discuss more about the approach, because almost every question is based on the approach. So I'll take one topic, I'll discuss in the Telegram group what topic you want, and we'll go with them. I'll try to put like an algorithmic approach, what is done now as up to date in the clinics, right? And based on that we'll come to the conclusion of diagnosis and maybe few pointers regarding the treatment as well, fine. We'll see you soon from November. It'll be in the Unacademy app in the form of special classes, fine. Thank you for your time. Bye bye.